Hi, this is Samantha Littman doing the case study presentation on gestational trophoblastic disease. This case study involves a 19-year-old woman in her 18th week of pregnancy presenting with vaginal bleeding. She has a history of two previous pregnancies, both of which ended in spontaneous abortion. Upon examination, her uterus size was consistent with that of 24 weeks of gestation. Her vagina contained blood and few grape-like vesicles protruding from the cervical os. Upon ultrasound examination, her endometrial cavity was filled with multiple vesicles in a snowstorm pattern. No fetus was identified. Her serum beta-HCG level was at 500,000. A dilation and curettage was performed, and it was productive of abundant bloody grape-like vesicles. The patient did not feel well and is discharged 2 days later, but does not follow up. 4 months later, the patient has a grand mal seizure, is brought to the ER, and begins to cough up blood. A chest X-ray is performed, and they found multiple bilateral pulmonary nodules. A transbronchial biopsy was performed, and her serum beta-HCG levels at this time was 600,000. The first article reviewed is a gestational trophoblastic disease overview. GTD is a condition that results from the abnormal development of placental tissues. Conditions include hyatidiform moles, molar pregnancies, and gestational trophoblastic neoplasia, which include invasive moles, choriocarcinoma, and placental slight trophoblastic tumors. Hyatidiform moles are atypical growths of trophoblastic cells that would normally develop into the placental tissue. This tissue fills the uterine space, creating grape-like structures. Risk factors for this condition include maternal age of less than 16 or over 40 and a history of molar pregnancies. Molar pregnancies have two types. Complete mole is when the haploid sperm fertilizes an empty ovum. Paternal tissues within 46XX karyotype are created, and no identical fetal tissue is found. This condition produces unusually high human chorionic gonadotropin, or HCG, levels. Uterine size is greater than expected from the rapid proliferation of tissues, and dark red vaginal bleeding, hypertension, hyperthyroidism, anemia, hyperemesis gravidarum, and ovarian enlargement, and theca lutein cysts are made. A partial mole is when a normal ovum is fertilized by two sperm. In this condition, paternal and maternal chromosomes are in the fetus. It creates a triploid 69XXY karyotype. Identifiable fetal tissue is created in this condition. However, it is non-viable with congenital anomalies. HCG levels are within normal range in this condition. Uterine size is normal. However, they have dark red vaginal bleeding and symptoms of missed or complete abortion. Treatment for both of these conditions includes dilation and evacuation procedure to remove the pregnancy and a suction curettage to lessen the chance of a uterine perforation. Gestational trophoblastic neoplasia is another condition under GTD. It can occur after a normal pregnancy or a molar pregnancy. Trophoblastic tissue invades the myometrium and can enter the uterine blood vessels and metastasize. It can begin as an invasive mole, in which edematous chorionic villi extend directly into the myometrium. It can occur after normal pregnancies and after evacuation of complete hyatidiform moles. Prolonged vaginal bleeding occurs and persistent levels of HCG. This condition is treated with chemotherapy. Choriocarcinoma is an abnormal trophoblastic tissue that turns into epithelial malignancy. It has vascular invasion and high risks of early systemic metastasis, commonly in the lungs, vagina, brain, and liver. Symptoms of the condition include hemorrhage, including hemoptysis, cerebral bleeding, and hepatic hematoma. This condition is treated with chemotherapy. Placental site trophoblastic tumors is a tumor that arises from the placental implantation site and can occur after any pregnancy. Intrauterine gestation, ectopic pregnancy, or a spontaneous and induced abortion. This one does not contain the chorionic villi, and limited HCG levels are secreted. It also is of slow growth. Symptoms may not appear until after the pregnancy is over. The symptoms include irregular postpartum vaginal bleeding, uterine subinvolution, and low serum levels of HCG. This condition is treated with a hysterectomy. The second article reviewed is called Management of Gestational Trophoblastic Disease, a survey of New Zealand O&G practice. Its purpose was to obtain information on pathways of diagnosis and management of molar pregnancy/gestational trophoblastic disease across New Zealand. The protocols used, and in addition, to consider the views of the O&G specialists on a national GTD reference center. The methods of the study involved a 10-question electronic survey that was sent to registered obstetricians and gynecology specialists working in New Zealand. They wanted to get information regarding their current practice in the diagnosis and management of patients with GTD. The results of this study, there were 68 out of the 234 questionnaires that were sent that were returned and analyzed for the study. The questions that they asked on the surveys are as follows. Answers to some of the questions were, do you routinely send products of conception for histopathological analysis? 79.7% of the specialists always sent tissues, while 7.8% did not, and 12.5% do sometimes. What influenced their decision on sending the obtained products of conception for histological analysis? Those that did not submit based their decision on ultrasound 80% of the time. They also 80% of the time based their decision on appearance of the tissue and 60% of the time on clinical presentation. Those that submit sometimes relied on 87% of the time on ultrasound, 62% of the time on appearance, 75% of the time on clinical presentation. They were allowed to choose more than one response. Another question was, do you think that some of the molar pregnancies are missed, and if so, why? 65% of fellows thought that GTD is being missed through current referral practices. 69.8% believe that an increased number of the medically managed miscarriages is the main reason. Another question asks if they are involved in management of GTD in their current practice. Among the responders, 10% were gynecologists or oncologists that provide consultations and treatment of persistent GTD. 66% of generalists were involved in patient care by performing D&C and following the HCG levels post-procedure. There were many other questions, however, I'm not going to go over all of them. In conclusion, it is concerning that 20% of the time products of conception are not examined routinely. This study calls for reestablishing national data collection in the form of registry or registries and some degree of consistency in the diagnosis and management of GTD under the supervision of the oncology services. The third article reviewed is on the psychosocial aspects of treatment and follow-up in women with gestational trophoblastic disease. The purpose of the study was to analyze the psychosocial experience of women with gestational trophoblastic disease undergoing treatment or monitoring prior to gonadotropic remission. The methods used in the study involved participants from a had-to-form mole registry in Victoria, Australia. 55 women were mailed information about the study and asked to participate. Of the 55, 9 agreed to participate. They used data from medical records and semi-structured interviews to get their information. The topics of the interviews included a response to and understanding of the diagnosis, satisfaction with care, impact of the diagnosis on intimate relationships, support received, and thoughts on future pregnancies. Here are the results. When asked the response to the diagnosis, they indicated feelings of shock, fear, shame, and disgust. When asked about their understanding of the diagnosis, the women felt confusion about the causes and lingering uncertainty. When asked about their satisfaction with the information, more were satisfied when they received information from specialists than when they received information from hospitals or general practitioners. When asked about their experience of treatment and monitoring, they protracted and were emotionally challenging. When asked about the impact on their partner and intimate relationships, they found that there was a greater closeness and better communication after all of it was done. They indicated there was initially a decrease in sexual activity and a lack of recognition on the impact of the father. When asked what ways they were coping, they included distraction and information seeking, minimizing seriousness of the situation, and some consumed alcohol, tobacco, and food. When asked about support from family and friends, the answers were generally good but limited because of a poor understanding of the condition from family members. When asked about their thoughts about future pregnancies, they indicated fear and anxiety. The conclusion of the study was that there is more effort that needs to be put toward patient and physician education about gestational trophoblastic disease. There is also more that needs to be put into the psychological needs of the fathers.